To all my patients, hello. If I say anything wrong, just correct me.
Afternoon, one more time. Can you all hear me? Okay. Most of you in the room probably remember the first time Cal approached me about doing this presentation, and I reminded him that I was an OBGYN. So, a little uncomfortable with this topic. Fortunately, Cal was able to find Dr. Langley, who's really going to do the bulk of this presentation. I'm going to give about a 10 or 15 minute kind of an overview of prostate cancer and recurrent prostate cancer and therapies. This is going to be
Yes.
Yikes. Is that better? I did it again. Is that better? Yeah. Okay. Now. Yeah. So what I'm going to do is to just give a 10 or 15 minute overview, and then I'm going to turn it over to the expert in the room. Before I get started, let me just introduce, for those of you, for the few of you who don't know Dr. Langley already. Dr. Langley is originally went to Abilene Christian in Abilene, Texas, and then went to medical school at Baylor School of Medicine. He then moved to the University of Virginia, where he did his residency in general surgery and urology, after which he returned to Houston and did a fellowship at MD Anderson. He moved back to Virginia and became quite a star in Virginia. He was actually president of the Virginia Urological Society, among many other things. And finally saw the light and moved to Hilton Head Island in 2009. Again. And some of you all might remember Dr. Vanderslice, Rick Vanderslice, but he and Dr. Vanderslice knew each other quite well. So I'm very pleased that you were able to join us, Dr. Langley. And after my brief remarks, we'll turn it over to him. I do also want to mention to you all that there are several articles that I brought that are just basically informational about support groups in the area, and also just some overview information about prostate cancer in general. So I hope that you all will avail yourselves of some of that material that's available as a way of not only finding out about support groups, but just sort of some general knowledge about prostate cancer. With that, let me begin. The first slide is basically a very important slide in the sense that one of the things that we, particularly as African American men, tend to need to understand is that knowing about prostate cancer and what some of the issues are, particularly for African American men, gives us the knowledge that we need to have the power to make sure that we can not only get treated early enough, but also to maintain our sanity during the course of treatment and thereafter. I know there are a lot of you in the room who are prostate cancer survivors, and some of you have had, I believe, a recurrence as well. I'm about 12 years out from my radical prostatectomy for prostate cancer, so I have intimate knowledge of some of the issues that arise from that. The next slide, please. So the first thing I want to mention to you all are some of the disparities in diagnosis and treatment, and just like just about all other aspects of medicine, African Americans do have significant disparities, not only in diagnosis but also in treatment. We are 1.5 times more likely to get prostate cancer, over 2 times more likely to die from prostate cancer. A lot of that is related to the fact that many of us present with advanced disease, and we're much less likely to receive novel hormonal therapy. And Dr. Langley is going to go into a lot more detail about some of the incredible new therapies associated with this disease. Financial toxicity, however, is a problem, and what I mean, I thought that was an interesting term when I saw that, but essentially it means that some of these treatments are very expensive. If your insurance doesn't cover it, that's prohibitive in terms of your ability to access some of these therapies. Fortunately, that's becoming less of a problem, but again, I'm sure he's going to want to elaborate on that. In many communities, particularly marginalized communities, the healthcare practitioners in that area oftentimes either do not have access to the resources that other practitioners might have, or have the education or educational background to understand the importance of some of the early treatments that can be used and some of the therapies that can be used for this issue. And then, as with so many other things, the issue of implicit bias is not exist in healthcare just as it does in all other aspects of our society. And with that come trust issues, and particularly in healthcare. Of course, everybody always repeats the Tuskegee syphilis study, but there are so many other examples of ways in which healthcare has not been kind to marginalized populations in this country. Next slide, please. So I cannot stress enough how important it is to get PSA testing. And for African American men, typically PSA, and that stands for prostate specific antigen, but typically PSAs you start getting around for age 50. For African American males, we recommend that they start getting PSAs at age 45, and some people even recommend getting at age 40, particularly if you have a first degree relative, such as a father or a brother who's had prostate cancer. So I cannot stress to you enough how important it is to get PSA testing on a regular basis. Typically you get PSA testing annually. The reason for that is that if your PSA starts going up, then that doubling time, if it's less than a year, is often associated with cancer or aggressive form of cancer. So it's important to make sure that you get your PSAs done on a regular basis. Should you get an increase in your PSA, then there are several tests that are done after that. And I don't know how you feel about digital rectal exams anymore. But
you still do it?
Yeah, okay.
It's still good.
So, we still, okay, fine. I forgot there are a few of you who know about it. Okay.
It's becoming a lost art.
Right.
Yeah, which is interesting, but we'll talk about that.
Yeah. So, other tests that are done obviously are biopsies, and they're usually done transrectally to identify areas within the prostate. Oftentimes those are ultrasound guided to help dig out the more suspicious areas. Also, you may have an MRI prior to that time. The sort of the latest, greatest way to diagnose these areas is with what we call PSMA PET scans. And essentially there's an antigen or an item on the surface of the prostate that is a specific antigen that can be identified, that's oftentimes associated with cancer. So those are all things that are used in order to be able to make the diagnosis of prostate cancer. Then, as you know, you get, for those of you who had prostate cancer, you get a Gleason score grade group, and essentially okay.
Yeah.
Better?
Yeah.
If I start wandering like that, just kind of raise your hand, okay? Once you get your Gleason score of 6 or greater is usually associated with cancer. If your Gleason score is below that, then that's not something that you need to be concerned about, other than continuing to get your PSAs on a regular basis. There's also some new data to suggest, and again, I think Dr. Langley will touch on this, is the importance of genetic and genomic testing. In African American males, about 10% of prostate cancers are associated with inheritance. So that goes back to father and first degree relatives having prostate cancer. But there's also genomic testing. All cancer cells are essentially mutations of normal cells. So there are certain mutations that are more aggressive than others. So there's some evidence to suggest, and again, particularly in African American men, that doing genomic testing may have some value in picking up the more aggressive types of cancer cells that may need a different type of therapy. The more, in some cases, you may be recommended for active surveillance. Personally, I'm not a big fan of active surveillance in the African American community, just because I think because that risk factor already exists. And if you do have at least a grade score of 6, I would be concerned about active surveillance. Again, I should have comments to be made about that. And then, of course, there is, after that, then the next set of therapies is either surgery, radical prostatectomy, either open, laparoscopically, or robotic. In this area, laparoscopic and robotic prostatectomies are now available. So they're
All robotic.
right. And then there are a slew of different types of radiation therapies that are used, both external beam as well as seed or other forms of radiation therapy that are much more focused and less likely to cause side effects associated with radiation therapy. There is proton therapy available, but proton therapy is extremely expensive, and as far as I can tell, there doesn't appear to be good evidence that it's any better than some of the therapies, the radiation therapy and surgical therapies that are already out there. So, next slide, please. The biggest thing is what happens after you've been treated for that initial diagnosis of prostate cancer. And a lot of times we tend to miss some of the easy stuff that you can do in terms of making some healthy lifestyle changes, making sure that you maintain a good weight, because obesity can be associated with an increased risk for recurrence. If you have diabetes, maintaining your diabetes under control, because again, that also can be associated with an increased risk of recurrence. So diet and exercise can, and I know you hear this over and over again with anything we've talked about in medicine, but diet and exercise really are truly important in helping to reduce the likelihood of your getting a recurrence. The other thing is, and this is the thing that I think kind of scares most of us the most, is some of the side effects associated with therapy for this disease, and particularly as it relates to urinary symptoms, and especially erectile dysfunction. There are a slew of different therapies for erectile dysfunction, and typically there is a therapy out there for you, but you have to make sure that you get that you follow up on that, and that you talk with your physician about different methods that can be used. Obviously, the one that's the most common is Viagra or something similar to what we call a PDE5, I think it is, inhibitor. And these PDE5s are good about 60% of the time, but there are so many other different things that can be added to that, both in terms of penile injections and also penile implants, among other things. So again, we may want to talk about that a little bit more. Also, emotional health is extremely important. Again, this is something that you really want to rely on your family for, as well as your church and other support systems in the community. And like I said, I've left some information about that. Again, for follow-up after prostate cancer, I don't think I can emphasize enough how important it is to make sure that you maintain your PSA testing. And for right after you have surgery, you're going to get that testing done a little bit more frequently, about every 6 months. And again, after 2 or 3 years, again, I think it probably depends on who your provider is. You might be able to space that out to annual testing, but don't ever give up on your annual testing for the rest of your life. Okay. A lot of people think after 5 years, hey, I'm free, everything's okay. But prostate cancer is a lot like breast cancer. In fact, breast cancer, having a first-degree relative with breast cancer, is actually a risk factor for prostate cancer. So that's another thing you should keep in mind. And like breast cancer, it can come, you can see recurrences that occur much later than that 5-year period. So maintaining your PSAs, picking up on that because what you want to do if you have a recurrence is you want to get that recurrence when it's what we call a biochemical recurrence, okay? And the reason for that is that biochemical recurrences, there is a panoply of therapies for that work very well, that maintain that 5-year survival rate of over 97%, which is what we all try to strive for, okay? When that cancer begins to spread, when it's either in a local bed or more importantly, when it becomes metastatic or distant disease, your 5-year survival rates begin to go down. So the earliest you pick up on this cancer, the more likely you are to live a long and fruitful life. And again, I just can't stress that enough. Next slide, please. So again, Dr. Langley is going to talk to you about some of the salvage therapies for local recurrence and systemic treatment. But again, all of these require a personalized multidisciplinary approach, and working very closely with your healthcare team will help you, and working very closely with your family will help to determine what the best approach for you will be. I can't tell you, I mean, in reading through all the information on prostate cancer, there are just an incredible amount of therapies out there. Many of them are new, and again, I'm going to let Dr. Langley talk to you about that. But most of these are new and what we call novel hormonal therapies, or targeted radiotherapies, immunotherapy, genetic gene therapy. I mean, the field is just exploding in terms of the number of things that you can do if you get diagnosed with metastatic prostate cancer. So, that's a very important part. Lastly, what I wanted to present to you is the importance of getting the emotional support that you need in order to get through this, because I know we're all very stoic and everything's fine and all that kind of stuff, but you really do need to have the people around you who can help support you through this, because even if you sail through this, there are going to be times when you really are going to need that support, and I can't say that enough. And part of that not only is your faith, but also your family, and there are support groups in the area. The one that's probably the most active is a group called the Zero Prostate Cancer Support Group out of Savannah. The leader, that Jerry Thomas, is very committed to this work. So, next slide. Is that the last slide? Yeah, okay, good. That is very committed to working with anyone, and I've left his contact information. There is also some excellent resources online, both through the Prostate Cancer Foundation and through the Prostate Cancer Research Institute, which for those of you who want to go into more in-depth, you can find the information that you need on that. So with that, I will conclude and turn it over to the expert. Thanks a lot.
Just real quick before Dr. Langley starts, a couple of housekeeping items. Number one, Doug is videoing this meeting, and hopefully I'll be able to put a link online, so if something you wanted to go over that you thought you might miss, I hope to be able to have this online before our next meeting. And if anybody ordered a meal to go or an adult beverage, please make sure you see your server before you leave, because if not, I'll have to pay for it and I will haunt you forever. Dr. Langley.
Did everybody eat?
No, you got one.
And which was?
Catfish.
Got it.
That's good.
So we can do this however you guys would like to do this. There's some great questions, like there's some really good questions that have been sent up for addressment. We can talk, if it would be helpful. I know several patients in here have prostate cancer or have high PSA. So would you do we want to start with just the PSA screening in terms of diagnostics, or do we want to jump to treatments for prostate cancer, or where would you like to start?
Yes.
Great. So the first question, which is really good, is there situations where you can have a false PSA result? So the current screening guidelines would be to have a digital rectal exam, which I find very few physicians do anymore, particularly primary care. It's not essential, but we find it valuable in urology. But the bedrock screening test is your PSA blood test. And the PSA test, urologists would say should start at age 40. I think you'll find it hard to convince your primary care physician or provider to do a PSA on you in your 40s, maybe impossible. That stems from billing issues and billing confusion vis-a-vis private insurance versus Medicare. But I would get your PSA tested at age 40 and beyond. Now the problem with the PSA test is there's several false positives for a PSA test. The first is, unfortunately, lab error. So we would always tell any patient that had an elevated PSA to get the PSA level rechecked and confirmed before you would do any workup on that. And what has also changed has been the PSA norms have changed. So we used to say your PSA can be normal up to 4.0. That's sort of changed a little bit now, where we would almost say 2.7 and higher probably should merit some consideration. Typically, if the PSA is over 2.7, we would recommend it be repeated in 3 months and see if it really is over 2.7. And if it is, then I would think that's the time for the urology referral. So if your PSA is over 2.7, it's repeated as over 2.7, and you come to the urologist, you're going to get a digital rectal exam. And the reason we do that is that some cancers that you can feel don't express PSA protein very well. In fact, it's almost counterlogical. Aggressive prostate cancers may not raise the PSA because the cellular morphology is so changed, the genetics, that it can't produce the protein. So that's why we still think that the DRE, digital rectal exam, is pretty important. Yeah, well. So let's say the digital rectal exam is normal, your PSA has been repeated at over 2.7 twice. I'd say now, anywhere in the US, you're gonna get a prostate MRI next. I think it would be unusual for a urologist to recommend just going to a biopsy without an MRI, because the MRI now guides the actual biopsy technique. So an MRI takes 30 minutes, maybe 40 minutes. You're in and out of the magnet. Some people find the MRIs intimidating, claustrophobia inducing. But the MRI is designed to tell us, is there anything going on the interior of the prostate that worries us? And they're multiphasic, they're looking at lots of different issues. You're going to get 6,000 images of your prostate on an MRI, and that gets read by the radiologist, but it also gets read by, guess what? AI. So this is one of the things, AI has made a huge difference for the good, because your radiologist is not going to sit there and look at 6,000 images of your prostate. So the MRI is greatly augmented by AI. So if your MRI is normal, but your PSA was elevated, and your digital rectal was normal, then the decision is, do you do a biopsy even though the MRI was normal? Most urologists would say yes, because you haven't explained necessarily why the PSA is high, even though the MRI was unremarkable. So things that can falsely raise the PSA. If you have a really big prostate gland that's not malignant, your PSA is going to be high. Second thing would be if you've had an infection or prostatitis or some kind of inflammation, it can falsely raise your PSA. And then there's a couple of things that I would say are probably soft calls, but if you say have had the rectal examination the same day or the day before you did your PSA, it can falsely raise it. If you've had an ejaculation within 48 hours of the PSA being drawn, it might raise it a little bit. That's pretty questionable, by the way. But those are sort of the things that might lead to a false high PSA. That's why we really have you repeat it if it's elevated that first time. Most MRIs are done in such a way that they can then be used to guide the biopsy if the biopsy is necessary. And most biopsies, I'd say, in the US are done transrectally with ultrasound, except in Hilton Head and Bluffton. So we do all of our biopsies transperineally without ultrasound. They're done with your MRI. So we use MRI-guided template biopsies, and we've been doing those only since 2016. So we haven't done, I don't think we've done a transrectal ultrasound-guided biopsy in 8 or 9 years. We've been blessed here to have, at Coastal Carolina, we had an administrator about 10 years ago who was willing to spend money and integrate an MRI robotic Artemis biopsy program. And we were the first one in the state to have that. And I think at this point we've done probably over 6,000 MRI guided biopsies. So you're asleep for this biopsy, and procedure takes 15 minutes. You go home the same morning. Most men are back to normal the next day. You have blood in your urine off and on for a few days, but the biopsy, which to me was much more intimidating 10 years ago when they were done transrectally with you on your side, sweating bullets while you were awake and the needles were fired across the rectal wall, expert in the corner part. And so the biopsy procedure is completely pain-free because you're asleep for it. Then we'll go down the tangent of the biopsy results and all that stuff. So that, sort of in a nutshell, is screening for prostate cancer. But the problem is getting the PSA done. I think you have to be proactive. And I tell patients this now, unfortunately, the way healthcare has evolved in the US is you better be your own best advocate and your family better be your second best advocate.
Amen.
And sidebar item, I think that's true for if you're in a hospital somewhere. I don't care if you're in the hospital at Cleveland Clinic, MD Anderson, or the General Hospital in the middle of the city. You need somebody as your advocate. That's just the way it's evolved, for better or worse. So we've got the false alarm, the false positive PSAs. We'll go ahead and address some of the questions now because they're sort of pertinent. Does terazosin or the prostate medications that a lot of you probably take for your prostate prevent prostate cancer? No. There's one medication that in some circles is thought to prevent prostate cancer. That's a drug called finasteride, which a lot of men take to shrink their prostate gland, so it can impair prostate cancer growth. But on the dark side of the coin, it can also perhaps cause higher risk prostate cancer. So that's kind of a mixed blessing with that one. Does shame and pride play a part? Yes, I think fear is a potent motivator. If you've got a high PSA and you don't address that, I think that's a big mistake. It's ignoring a potentially life-threatening problem. So family helps with that as well. For sure. Yeah, I think, we have patients that every day I see that I know they have a problem that is probably serious and needs to be addressed. And we kind of go over the treatment plan and what we recommend, but ultimately, the patient has to say, okay, I'm going to do this. And that's where, if you get your family involved, they have better peer pressure on you than the doctor does, way better. So there's some questions about if the diagnosis is made. So let's do that real quick, or we can go in the weeds too deeply. So if you've got prostate cancer on your biopsy, the biopsy is going to come back about a week from the time you did your biopsy, and it's going to be graded if it's malignant. It's going to get a Gleason grade assigned to it. That's an old system. It was from the 1960s, and it's sort of being replaced by a little bit better system called the grade grouping system. But for the sake of the argument, Gleason goes 6 through 10. 6 would be the lowest risk prostate cancer based on the histology. 10 would be a very aggressive cancer. So we will do genomic profiling on every prostate cancer that we diagnose histologically. So if you have a Gleason 7 prostate cancer, your biopsy tissue is going to get sent to a genomic profiling company, and there's 3 that do this, and they basically look at your messenger RNA from your tumor cells, and guess what? They profile how that cancer is going to behave, and they are accurate. If you think about it, your pathology is an interpretive science, because it goes to the pathologist and they stain the tissue and they look at it under a microscope, and the guy says, Sally, do you think this is a Gleason 7 cancer? And Sally, the other pathologist, says, well, yeah, I think it is. But that's an interpretive science, right? They're staining the tissue and looking at it. The mutation profiling, the genomic testing, is not subject to error or interpretation. You either have these mutations, your cancer is either expressing these mutations or it isn't. So we actually base our treatment recommendations oftentimes as much or more on the genomic profiling of your biopsy than on your actual histology. So if you've got prostate cancer newly diagnosed, you're going to get stratified as low risk, intermediate risk, or high risk, and that's based on the pathology and the mutation profiling. And then the treatment plans evolve from your risk stratification as to what would likely be recommended. And I think to sort of lump it into 3 options, so for low risk prostate cancer, active surveillance, which is a sticky wicket. Active surveillance is absolutely an option. I think the genomic profiling has made active surveillance a lot more safe to do if you know you possess no key mutations that allow the cancer to metastasize. Then active surveillance is a good option. However, some of you guys in this room can probably say and agree active surveillance is pretty active. So, meaning that you're not going to get any treatment, but you're going to have a PSA test every 3 months. You're going to have a repeat MRI and or biopsy in 1 year. And guess what you're going to do the second year? You're going to do the same thing the second year. So you get to see the urologist 8 times in 2 years, and you're going to have MRIs, and it's an extremely active process whereby I think we probably don't see prostate cancers turn from something that looks not serious to something serious, and that is all based on that initial genomic profiling. So if you have intermediate risk prostate cancer or high risk prostate cancer, you're probably going to be offered one of 2 treatment options: some type of radiation versus prostate removal. And each of the two is loaded with danger and potential problems, but they're equally effective for intermediate risk prostate cancer. So at 10 years, if you had radiation therapy for your prostate cancer, or if you chose to have your prostate removed, and you have intermediate risk prostate cancer, your 10-year disease-free survival is a dead heat. So there is no advantage of radiation over surgery in a 10-year follow-up in intermediate risk. If you are a high-risk patient, that changes pretty significantly, because if you have high-risk prostate cancer, you're going to get multimodal therapy now. Multimodal therapy means that you're going to get some kind of hormone therapy as an adjunct to either your surgery or your radiation, and you may get all three. So the higher risk patient is a whole other subject upon itself. But for the sake of argument, when patients come to us with intermediate or even low risk prostate cancer, I can't tell a patient that surgery is better than radiation, because it isn't. In some situations though, the issue with prostate cancer now that we see is the use of hormones. Hormone therapy means we give you medications to castrate you chemically for X period of months or years. So these drugs can be given as a pill or a shot. And the effects of those pills are going to be, you can get hot flashes similar to a female going through menopause. You can get muscle weakness, proximal muscle weakness, meaning it's hard to sit up or to stand up from a sitting position. You can experience cognitive decline. That's typically more if you're going to need to be on hormone therapy for a longer period than 6 months. In some cases, you're only on the hormone therapy for 6 months. But I would say that in 2026, if you're going to receive radiation therapy for your prostate cancer, which is a great option, most of the time the radiation therapist is going to want you to receive hormonal therapy for probably 6 months at least. You don't have to do hormonal therapy with your radiation therapy, but it is felt to be advantageous. If you go the surgery route for your intermediate or your low-risk prostate cancer, you're likely not going to need hormone therapy. It's just not in the treatment paradigm at this point. So maybe that's an advantage for surgery over radiation. That's probably up to the dealer. Higher risk prostate cancer, when we say multimodal therapy, most of the time the hormone therapy is the foundation, unfortunately, of treating high-risk prostate cancer. You may receive radiation and or surgery, but you're going to get on hormone therapy. And for high-risk prostate cancer now, the recommendation is at least 2 years of being on hormonal therapy. Somebody asked a fantastic question. Can you say something about estradiol instead of androgen deprivation therapy? So when we say androgen deprivation therapy, we're talking about either a shot, which is called Lupron, or you can do, there's a new pill, Orgovyx, that does the same thing that may be safer. In Great Britain, and we've used it here, some patients you can use an estradiol patch instead of Lupron or Orgovyx, which is an ingenious way of reducing the effect of the testosterone, but you don't get the hot flashes, and you typically don't get the potential bone weakness and proximal muscle weakness that you get with the true androgen deprivation therapy. So estradiol is Can you hear me still? So estradiol patch is a clever way around some of the side effects of the Lupron or the Orgovyx. We don't use it a lot in the US. I've used it in selective patients, but I think it's probably, in in some ways superior. When I was finishing residency a lot of years ago, DES was a pill, estrogen pill, and that's what men took for metastatic prostate cancer was DES. And there was a lot of cardiac risk factors, so kind of got away from that and then went to these ADT drugs like Lupron. But the estradiol patch is a clever way around it, but very hard to get approved pharmacy-wise. We do. That data isn't real clear, but what's popular in some circles is what we'll call intermittent androgen therapy, where you'll get your Lupron for 6 months and it will back off, and then maybe you get a shot a year and a half later to try to minimize. The biggest worry about the androgen deprivation therapy long term is the cognitive decline, I think. That's what really, obviously nobody wants to get Alzheimer's disease or dementia, but those drugs long term, longer than 2 years, there is a big legitimate concern about cognitive function. So I derailed myself there. So, but estradiol is a very reasonable adjunct. When we do estradiol, we do it as a patch, and it is really hard to get it covered for a male, because the Veldoc patches are for females, right? So you go to the pharmacy with the prescription and you're a guy. That creates some consternation on the pharmacist and the payment. Well, that's been done. Let's see. There's a good question here talking about the older patients. If you're 89, and you have an enlarged prostate but not cancer, how often should you have the PSA test? So there's a number of agencies that contract with Medicare, and they come up with these screening recommendations for various cancers. And my sardonic take on that is that they're trying to save Medicare money. So the guidelines now say after 72, you guys shouldn't have a PSA test. That's the guideline, the U.S. Preventive Task Service, which is slang for let's don't spend any of Medicare's money, right? So we never adhered to that. Urologists, we've always said you get a PSA as long as you, well, first of all, as you want one, but we get them annually on everybody. But your family doctors, your primary care providers see the USPT screening guidelines and go, you're 74, you don't need a PSA. You'll die of something else. That may be true, but it also may not be true. So I think you have to leverage, again, it gets back to you have to drive your own health care. You got to steer the boat. Just tell your primary care provider, if you don't, just order me a PSA. And guess what? They'll usually do it. They may advise you against it, but that's okay. Staging. Here's a good question. So we'll continue the theme. So you've had your biopsy. You've got intermediate risk prostate cancer. We used to do a bone scan and a CAT scan to stage the disease to make sure it's not outside of your prostate. And I would say that pretty much the PET scan, a PET scan is like a CT scan. The difference is they give you a radio tracer injection that goes to wherever your cancer cells are. And we're lucky enough now that there's a different PET scan for most every cancer. So each cancer, colon cancer, lymphoma, leukemia, breast cancer, prostate cancer, all sort of have their own PET scans that are used for that unique cancer. So with prostate, it's called a PSMA scan or Pylarify scan. So it's like a CT scan, except instead of giving you contrast through your IV, if you ever had a IV enhanced contrast CT, you're getting a tracer that goes to wherever there is PSA protein in your body. Guess what that is? It's your prostate or your prostate cancer. So now if you have your prostate cancer has escaped and you've got a 1 centimeter lymph node in your left lung that came from that prostate cancer, it's going to light that up. A bone scan and a CT scan are going to miss a lot of small metastatic deposits that the PET scan doesn't miss. The problem with the PET scan, guess what? Medicare and getting it prior authorized and approved, because a lot of Medicare Advantage plans want you to get a bone scan and a CT scan. So that's a whole other battle, and the PSMA PET scans are not cheap. So, and it's not the scan that's expensive, it's the PSMA, the Pylarify that they inject you with is about $12,000 for the stuff they inject you with. So, there's an incentive from the payers to not want you to get a PSMA PET scan. So, but we usually can get them approved with prior authorization and whatnot, if that's what we want the patient to have. So that's the PET scan. This is a question about if you've had prostatectomy, meaning your gland was removed and you've had radiation, are there other matters we should be concerned about? So, yes, because if you've had surgery and your prostate's been removed, your PSA should be 0.0 for the rest of your life. And if your PSA isn't 0.0, you've had your prostate removed, you've got recurrent prostate cancer somewhere. Usually it's in the pelvis where your prostate was. So in that setting, you're going to typically get a PSMA PET scan. The problem though is that from the side effect perspective, that if you have surgery, your major risk is going to be your bladder control after surgery. So you may need pads, you may need surgeries to help you with your urine control. The big advantage of the robotic prostate removal over open prostate removal has been the urinary control is substantively better with a robotic prostate removal than an open. That said, there's still a 5 to 10% risk of incontinence after you have your prostate removed in the best of surgical hands. The secondary risk factor is erectile dysfunction. And what we tell patients now is if you have your prostate removed, robotic or not, you are going to have erectile dysfunction. Hopefully that just means that you need Viagra or Cialis, and it typically does help a lot. But it can also be severe enough that Viagra or Cialis don't work for your erectile dysfunction after prostate removal. And then you're going down a different pathway of injection therapy, penile implant surgery, vacuum therapy, etc. So I would say for prostate removal, your worries are going to be erectile dysfunction and bladder control. And if you've had radiation after surgery, guess what? The risks of both are worse because you've had surgery to remove the gland, then you've had radiation therapy, and that's an additional burden on your bladder and on your erection pump. Where I think the question is leading us is to what about after those two things? What if you've had surgery, your cancer recurred, but it was in your pelvis, and you had radiation therapy to take care of that recurrence, and then your PSA goes up again. So you failed surgery and you failed radiation therapy. There's where you're heading down probably towards some kind of adjunctive therapy, immunotherapy, chemotherapy, or long-term hormonal therapy. Usually it's a combination of all of the above. But the problem, of course, is that the more treatments you have in terms of surgery or radiation, the higher your risk are of your bladder control and your erectile function. And stop me along the way, by the way, if you guys pop up questions, just ask me. And then here's a question about a patient that was on Zytiga, which is one of those drugs that's typically used for recurrent prostate cancer. I was on Zytiga for 2 years, on Lupron, still on Lupron. PSA has been steady at 0.1, so that's excellent. So your PSA after treatment, the only time your PSA is going to be 0 is if you've had your prostate removed. So if you chose radiation therapy for your prostate cancer, your PSA is going to be a measurable number because your prostate is still sitting in your pelvis secreting protein. So your PSA after radiation therapy is a little trickier to follow and manage, and it's also tricky to follow if you're on hormonal therapy or you're on these other sort of androgen receptor blockers like Zytiga is. The PSA is great in terms of the screening test. It's really great after treatment, but it can be a foggy number after radiation because of the fact that your prostate is still there. So, yes, we're going to jump ahead and we're going to go down the line. So there's some new, Pluvicto is kind of a new-ish one. It's not that new. It's a radionuclide that's injected sort of as a, when you get Pluvicto, it means you've probably failed most of the other adjuvant therapies. So your prostate cancer has recurred, you've probably been on hormonal therapy, you've probably been on an additional drug or two called doublet or triplet therapy, and your cancer is recurrent. Generally speaking, it's going to be in your bones at that point. So Pluvicto, depending upon which protocol you get put on, you can get up to 6 injections of Pluvicto every 6 months, but it's a radionuclide, basically goes to where the cancer is, and it disrupts the DNA synthesis in the tumors, and it can be effective for a period of months, but Pluvicto doesn't really cure you. It's more of a prolongation, quality of life thing with Pluvicto, and then there's going to be subsequent generations of Pluvicto and analogs like that coming down the pike. And you want to talk about expensive medications, Pluvicto. I think it's $62,000 per treatment, times 6. Now, you know, it can give, it will get covered at some level, typically, but it's a big burden again for the Medicare fund. This question is about again the aged patient. This is right. Okay, this is good. The slow-growing prostate cancers in the elderly. Absolutely. I'm tangential again, but this is kind of interesting. So there was a big study done that was published in 2016, so that's 10 years ago, called the PROTECT trial, and it was done in Great Britain and Europe. And they looked at thousands of men, and they had low or intermediate risk prostate cancer, and they put them in a randomized trial. So they took a third of those men and put them on active surveillance. They took another third of those men and they had a prostatectomy. They had their prostate removed. And the third group had radiation therapy. And they followed these guys for 10 and sometimes up to 15 years. So at 10 years, the mortality from prostate cancer was the same across all 3 groups. That is to say, dying of prostate cancer, you were no more likely to die of prostate cancer if you went on active surveillance than if you had surgery or radiation. which was fascinating because it just says that even aggressive prostate cancers aren't that super fast growing compared to other cancers. Now, beyond 10 years, active surveillance, meaning no treatment, surgical removal, radiation, when they got past 10 years, there started to be appearance of metastatic disease in the active surveillance group, which could then be managed, right? So that was a pretty sobering trial that didn't get a lot of play because it really said that, you know what, if you're 82 and you have just been discovered to have prostate cancer, if it's intermediate or low risk, your odds of being alive in 10 years are the same as if we did surgery on you or did radiation on you. That's the facts. So that's why if you're 82 and you don't have high-risk prostate cancer, doing watchful waiting active surveillance is not an unreasonable option to spare you the morbidity of radiation or surgery. But then you've got the 82-year-old guy who's going to live to be 102. That's a lot of patients now, by the way. So you have to weigh their health conditions, medicines, heart disease, all the other factors in there. So I would say that if you're 82 years old, it doesn't preclude you from needing aggressive therapy, keeping in mind that we know from a pretty robust study that doing nothing was as good as doing something for 10 years for the low or low intermediate risk.
But if you're 60, you have active surveillance, what would you say to that?
Well, you're looking at, let's say you're going to live to 90, so that's 30 years of active surveillance. And what has not been established with active surveillance has been, when do you stop actively surveying, right? Because you've got prostate cancer. We've decided it's probably not going to progress, so we're rolling the dice and we're watching your PSA. So I have a harder time in some cases with younger men. Having said that, that's been looked at time and time again, and younger men can absolutely be put on active surveillance safely, but you need to stay on top of it. With periodic MRIs and periodic biopsies. I have some patients there, it's hard to get them back in that biopsy room. Even though it's, like I said, it's, quote, you're asleep and there's no pain, and it's still an experience, right? So we have a lot of trouble with some of our guys. We're gonna do a surveillance biopsy next year, and they go, okay, we'll talk about it. We'll talk about it. And they come back and we talk about it, and never got that surveillance biopsy done, so. But we've got men in their 50s that are on active surveillance. Yes, sir.
Two questions. One, is there any merit to Kegel exercises as an option to retard ED?
Yes. So, two parts to that. First is that we try to get most of our patients now, I'd say as of last year, if they're going to have their prostate removed, we sort of try to have them do what we call prehab, where we'll have them learn to do Kegel exercises either with a pelvic floor therapist to show them how to do it correctly, or there's a new twist to every turn. Now there's a machine called an Encella machine. You can sit on this thing. Looks like a toilet seat without the hole. And it's a 2.5 Tesla magnet, and it does 12,000 contractions of your pelvic floor in a 20-minute period. And it can be real helpful. So before the surgery, you do that, right? So your pelvic floor is in maximal tone. So when you take the prostate out, you're taking away what we call the internal sphincter. That's the bladder, neck, and the prostate smooth muscle that helps you control your urine. So then when you have your prostate removed, you're winging it on just your pelvic floor muscle, that sheet of muscle which your prostate sat on. So if you strengthen that, your risk of incontinence after your surgery is lower. If the patients don't want to do prehab for their pelvic floor, then after surgery, absolutely, you can start them on a Kegel program, not right out of the gate because it's very, the operative inflammation and pain, but absolutely. We send a lot of men to pelvic floor therapy. I would say this, to try to do your own with just reading a text, how to do Kegels, they're not super effective, but with a pelvic floor therapist sort of showing you how to do them and what muscles to engage is really helpful.
I guess it's actually not a question, but I have a son in his mid-40s. My father developed prostate cancer, I believe he was about 72. On the basis of that diagnosis by his physician, I proactively went to my doctor, ultimately met with a urologist, and determined at 43, 44 that I had prostate cancer. My son is, as I said, in his mid-40s. I advised him about a decade ago to begin to share with his doctor that his father and grandfather both had prostate cancer, which means he has a predisposition to the disease. Doesn't mean he'll get it, but it's in his gene pool.
Yeah.
I believe that was good advice.
Really good advice. You could make the case for him to start in his 30s.
Yes.
The problem with PSAs in the 30s was an interesting one, is we don't know what the normals are. So we know it shouldn't be over 2.7, let's say. But I would say in a 35-year-old male, that PSA probably shouldn't be much above 1. Because the inherent, as the prostate ages, it produces more PSA. Same is true if I see an 81-year-old patient. I do this all the time. I'll see an 81-year-old patient who's referred with a PSA of 6. Seems pretty high, but there's some studies that show if you're 80, your PSA norm might be up to 6.5 to 7. But they've never done the study to define that, so it's sort of dealer's interpretation. The doubling time is key, especially after radiation therapy. If that PSA is, because it's never going to be 0 after radiation, but if it goes from 0.2 to 0.4 to 0.8 over a year.
What was the question? I don't think anybody heard the question.
He went to answer.
Right, oh, sorry. Go ahead.
Oh, so the doubling time. So PSA doubling time means each PSA reading is double from the previous one, and it's been used to guide treatment, I would say mostly after radiation therapy. Since the PSA doesn't go to 0 with radiation, let's say you have radiation and your PSA bottoms out at 0.4, which would be good. But then over 3 months it goes to 0.8, and then the next 3 months it goes to 1.6, and then it goes to 3.2. That would be 3 successive doublings, and that would be treatment failure, meaning you need something else done. On the screening thing, I would say an absolute PSA number, we mentioned that early on, you should always get that repeated. Say 6 to 8 weeks after your level was done, your family doctor says, hey, your PSA is 4.1, you need to go see the urologist. You've never had a PSA done. That would be a repeat. In 6 to 8 weeks, have it repeated, to just be sure it really is high. Beyond that, if it's doubling in a screening setting, if that PSA of 4.1 is 8 in 3 to 6 months, that's concerning. Yes, sir.
From a preventative measure, you alluded to something earlier about if you go to have a PSA test and you could ejaculate earlier.
Yes.
Now, in my mind, I'm sitting thinking, if you have a more active sex life, is that good or bad for
That's
PSA?
a great question.
Can you repeat the question?
Issue about if you're sexually active or a regular basis, how does that affect PSA? And when you do a PSA, because we really prefer you not have ejaculated, I would say 48 hours is reasonable. I thought you were going to ask, is frequent ejaculation preventive of prostate cancer? Boy, wouldn't that make us some money. Yeah. You're the envy of this whole crowd. There's just 2 beers, right? We only had 2 beers, officer. It's been looked at. There's sort of this urban legend. You read about it. Ejaculation and sexuality is preventive, or I don't think there's that much data to support that notion.
But it doesn't hurt.
But it doesn't hurt.
It's a good story to go home and tell you.
Don't go home and tell your wife you left this forum and the doctor said.
So I think that's the right answer. It doesn't hurt, but it is a challenge because I think I've seen a couple of articles that ejaculation can raise the PSA by 15-20%. So I think 48 hours of abstinence is probably the right number. I guess in an ideal world it would be a week. So you take that variable out. But you're going to always get it rechecked. If it's high that first time, we're going to recheck it anyway. So.
I
Yes,
think
sir.
it's just a statement. I'm glad you talked about the rechecking, because I personally had a situation where
my level was very high, but it had never been over, like 0.9. And right away the surgeon wanted to kind of do that biopsy,
Sure. Yeah.
physical biopsy.
Yeah.
And I thought about it and I said,
Why don't we recheck this
I
thing?
want to recheck this down the road. And after I rechecked it, it went back down to under 1.
Yeah.
So it was like a false positive, I
Yes.
guess. That's what you're talking about.
So the concern is, of course, you say, well, my PSA's high, and you're worried about it, and your wife is worried about it, and your family doctor's worried about it. You go to the urologist, and we say, let's do one in 3 months. As easy it is to say that, we are not taking any gambles with you in terms of there's a cancer there, we don't know it. If we wait 3 months, it's going to be escaped. It's a slow-moving cancer. Even the high-risk cancers are slow-moving in the scheme of things. So that 3-month wait, 6 weeks to 3-month wait to recheck your PSA, categorically doesn't gamble that we should have done a biopsy 3 months ago when his PSA was 4.1. That this is the way the disease behaves. It's not going to do anything significant in that short of a time frame. Everybody's going to go home and have sex now. See you later.
You gotta go. Slow down.
Get this for my friend.
I'm trying to think of stuff that's timely and current. So I told Ray, the joke is that if you are on, as a urologist, if you're on top of the literature this month, you feel like you've read every journal article about prostate cancer update, in 3 months, that knowledge is almost obsolete. This is a moving target. I mean, it's a vastly changing disease landscape, and the treatment options are ever evolving.
I'm currently, how you going?
Gentlemen, one quick thing. The kitchen is now closed. There'll be no more orders available. So just to let you know that don't expect to make an order as you're walking out the door, okay?
Any other questions? Have we exhausted you now?
I don't have a question, but I'll just kind of go forward since I began like this. I just want to share, because as we have already covered, the important thing is for us to continue to share information that we know from experiences, and so that we have what we call our interest groups, sit around and not be afraid to talk about what's going on in our bodies. And I have done this with a number of you all, and that's why, because I've been through just about everything that's been discussed here, I've gone through and still going through. When it was mentioned about Zytiga, I was on Zytiga, which was a chemical oral chemotherapy after my prostate reoccurred. And after 2 years on Zytiga, and I took it okay. But at the same time, I was also taking Lupron. And we'd use the word when people ask me all the time, why do you carry this towel? It's for my hot flashes. Sometimes I say it's my crying towel. Because I can tell you it's, the hot flashes at night are severe at times because you are pretty much castrated. But you know what? The beautiful thing is I'm gonna turn 85 in May, good Lord willing. So I've been at this for now going on close to 15 years and still doing okay. Now, erectile dysfunction, it finally kicked in because my doctor in MUSC, when we were going through all the process, he looked at me and he looked at Ed and he says, you probably have to make an appointment anyway, don't you? So you can prepare for when you want to have your intimate times. And so anyway, let's talk about it like I'm sharing with you guys, share with each other, whatever you're going through, because it's not a shame. It's a blessing to be able to still stay here and talk about it. Thank you.
Yes, sir.
Can you tell on cryogenic treatment for cancer?
We were talking about that earlier. Cryotherapy. Cryotherapy has had some dark eras. So 20 years ago, it was kind of a big disaster. So there was a push 20 years ago to do what we called total gland cryotherapy. So instead of surgery or radiation, there were a number of centers that would freeze your prostate. And that's done by putting these sort of things that look like knitting needles through the perineal skin. That's the area between the scrotum and the anus. And you would use argon and neon gas and form a freeze ball, and you would watch it with ultrasound. And so this freeze ball evolves. So there's this black abyss of freeze ball, and you would try to stop when you got to the rectum. And sometimes you stopped before you got to the rectum, and sometimes you didn't. So there was a lot of issues with fistulas from the prostate to the rectum, fistulas from the bladder to the rectum, fistulas from the rectum to the skin. So cryotherapy kind of disappeared, rightfully so. But now has a second life, as all treatments do. There's always something that comes back reincarnated, right? So now it's primarily used in a focal setting. So kind of a unique subset of patients, but getting back to MRI. So you have your MRI because your PSA was high. And the MRI, let's say, identifies one specific area of concern. And then you have your biopsy. So you're going to have, because the MRI guides the biopsy, so you're going to take a sample from the target area, and then we sampled the rest of the gland. So we got template biopsies from the whole prostate, usually 12 total, and then usually 3 biopsies would come from any specific target that was seen on the MRI. So fast forward, so if you only had cancer in the target area on the MRI, but not in the other biopsies, you become a candidate for focal therapy. And the idea would be that instead of putting these needles into the prostate and freezing the entire gland, you're only putting the needles into the target area where you know the cancer existed, and you're going to freeze just that area. It's very precise, it's good therapy, it's very safe, and it can be repeated in case there was treatment failure. So you don't see a whole lot of total gland cryotherapy done. There are some guys doing total gland therapy still. But that's kind of having a second life, so it's a pretty good option for patients. I was telling Ray, some of you guys maybe knew Dr. Cianti, who was here, gosh, he left in 2009. Anyway, he was in practice in Hilton Head doing mostly prostate cancer, and then he got interested in focal cryotherapy. And at the time, it was still pretty close to the bad era of total gland therapy, so he was pretty unique in still thinking it can be done focally. So he actually ended up leaving Hilton Head. He went to, he was on the faculty at Columbia, or maybe NYU. And then he was in Boston, and then he opened his own practice in Sarasota, Florida. That is all he does. He does cryotherapy focally for prostate cancer. He's done more than anybody in the world. But he was here on Hilton Head for 15, 20 years in private practice. So we would tend to send the patient that would be a candidate for focal therapy to him, because he's done over 10,000 cryotherapy procedures. Another modality is high intensity focused ultrasound, HIFU. So HIFU is usually for a little bit different location of these lesions than cryo is, but that's another pretty popular option. It's a niche patient though, because it's the guy that only had cancer in this one discrete area, as opposed to sort of spread like salt and pepper throughout the prostate, as is a lot of prostate cancer. Covered by Medicare, by the way. Cryotherapy and focal HIFU therapy all are now covered by Medicare. So that's been good.
I did 1 year ago, it wasn't covered.
Right. You were a pioneer.
Yeah.
Well, this has been very successful today, and it's only because of your participation. We cannot do programs like this if nobody supports it. So I want to thank you all for coming out. I know, being a prostate cancer survivor for the last 26 years, I even learned new things today, and I want to thank Dr. Langley and especially Ray, who did a lot of research outside of his area to make this work. Thank you guys. And I want to thank Al for bringing in the setup. Tim did a renovation, and trying to get people to complete things is very difficult, so he's still waiting for his AI guy to come in, his tech, to hook up the systems. And I know Bo did a little something special for our waitress. I know gratuities included with the price of your meal, and anybody that took part in that, we thank you, but it wasn't necessary. But Bo thought that since they were down like 3 people today, you didn't see much of Tim because he did all the cooking today. And we want to thank the staff for making it successful as far as our meal is concerned. And go home and have sex.
We also want to thank Cal. The whole team, not just Cal, the whole team.
Uh,